So, you know these pictures by heart, you have seen many times. It was in 2008, and 8 years later, the results are still very good in this very compromised child, the case published by Christine Labrèze in 2008. So we can consider today that really propanolol in infantile hemangioma is a real therapeutic revolution, and it's definitely a first-line treatment in this pathology. The indications are now well established, but as it's changed completely the management of a disease, many questions have arisen. And progressively, we have to answer together to all these questions. For the efficacy, no problem, is well established. For rebounds or relapse, I will show you also some data, but there are questions about the rhythm of administration twice or 3 times a day, about the safety profile, but also what about sequelae under treatment, the safety in at-risk population, of the efficacy in this population, the dose, the duration of treatment, how to improve referral to the centers, and so on. So about the efficacy, there are several reviews or meta-analyses that have been published in the recent years, and globally everybody says, okay, it improves hemangioma at least 80%, but usually it's more than 90%. There was one small clinical trial versus placebo published by the team of Orly Wagen in 2011, and they showed versus placebo that it improved better hemangioma, but the best results have been obtained in the international study that we managed, and that was published in 2015. You know these results also with a complete or nearly complete resolution of the hemangioma in 60% versus 4%. What about relapse? In the same study, we could show that it's around 11% of hemangioma that needs to restart the treatment after the treatment has been stopped at 6 months. And very similar results were observed by the team of Bordeaux in 2012, 2013, where they established on a retrospective study that the need for retreatment is about 12%. So some factors are of higher risk, such as deep or segmental hemangioma, and most of the recurrence occur during the 2 first months in the majority of the patients. More recently, that's the American team in San Francisco. They established that the relapse needed to be retreated was about 15%, and some predictive factors were established, also deep component, but an early stop of a treatment, and also in girls. What about the rhythm of administration? Twice a day, 3 times a day. Of course, due to the short half-life of elimination of propanolol, which is approximately 3-4 hours, the theoretical rhythm would be at least 3 times a day or 4 times a day. And that's something which is used in pediatric cardiology because they need to have a very stable concentration to control either arrhythmia or blood pressure, high blood pressure. But what about in infantile hemangioma? Because the mechanism of action is different, and probably we do not need to have a similar control of blood concentration. There was a short study that has been done in France during the development of the product, in 22 infants treated at 3 milligrams per kilo per day, and we established in 2 groups of children younger than 3 months at inclusion or older. And what can be seen, so the PK profile are very similar, and the PK parameter also, and particularly the clearance, that means the elimination of the products, and we have similar values, and that means that there is no need to change the dose according to the age of a child. in daily dose per milligram per kilo per day. So with these results, it's possible to make a PK modelization and to establish with these models different simulation. And that's a simulation. On the left, you have here 3 times a day. We did different simulation at different times of the day. And you have Cmax here, okay, approximately 16 nanogram per ml. And with twice a day, it's increased by 10%, 67. So it's a very limited increase of the blood concentration, and it's much less than the variability, inter-individual variability. That means that it's probably something appropriate to use only twice a day. It's easier to manage because it avoids some dosing error with a third person during the midday. And it's also proven to be efficacious because it was used in the multi-center study. And maybe the question now that we have to consider, should we establish another dosing scheme, for example, in some population at risk, in phase syndrome, or in subglottic hemangioma, or maybe in premature children? What about safety? The first results of a compassionate use program that has been done in France, the results after 3 years in almost 1,000 patients was published in JAMA last year. And more recently, at the end of the last year, we published a large review of the safety data. It concerns approximately 6,000 patients, with all the patients having used in the compassionate use program, and also the clinical trials, and a review, a selection of papers concerning approximately 4,000 patients. And globally, the conclusion is, okay, we know that it's well tolerated, and of course, if we respect some examination assessment before starting the treatment to eliminate some contraindication, but also some monitoring to minimize the side effects that can occur during the treatment. Okay, it's not possible to see on the right. If you consider the different sources of information, it's very difficult to compare because, you know, on the right here, you have the columns with a placebo, and there are a lot of adverse events, even under placebo. Even the adverse event considered by the investigator as related to the product, it's 15%. That means it's the same than under product here in the literature. So, of course, we have to consider that when we analyze the result. But there is something which is probably very common. It's the adverse event which lead to the discontinuation of the treatment, but enough severe to stop the treatment. And it's very constant, whatever the source of information, it's 2.5%. So keep in mind, 2.5% of the treatment will be stopped because there is a concern about safety. What about the evaluation, cardiac evaluation before starting the treatment? During the consensus in the US, it was clear that, of course, the medical history should be well documented, and also auscultation of cardiac and pulmonary auscultation, and also blood pressure and heart rate. So it was clear also at that time that it's not necessary to do a systematic echocardiography, except if there are some cardiac concerns already known. But it was unclear at that time, is it necessary to do or not a systematic ECG? And there was some discussion, And of course, they established some rules, of course, to do this ECG if there is a bradycardia, or if there is a medical history of arrhythmia, or if the arrhythmia is detected during the examination, or if there is some medical family history. So from that time, there are different papers, and in the most recent ones, there is the pitch survey in Europe, and it's interesting to check the results. What happened in terms of hypotension and bradycardia if the patient had previously an echocardiography, and it's not more frequent. Here you have hypotension, bradycardia, and it's not more frequent if the patient had previously echocardiography or not. And the same for ECG, maybe a little bit, but it's not statistically significant. You cannot see the column. So more recently, two interesting papers. The first one is coming from two teams in the US, and they detected anomalies at the ECG in 43% of the babies, but none of them was a contraindication for starting the treatment. No of the adverse events observed during the study could be prevented by a systematic ECG, and there were not more frequent adverse events in the group with an abnormal ECG or in the group with normal ECG. But the most interesting in this paper is that they have established what would be the risk of for patients treated with oral propanolol for infantile hemangioma, and that could have an underdiagnosed cardiopathy, bradyarrhythmia. That means because we do not do an ECG, and in that case, we could have a risk. And they established this risk lower than 1 for 10 million. So that means now we have to consider, do we perform a systematic ECG for all patients, or do we have a pragmatic attitude and to do this full examination in the patients that are at risk? And the second point they mentioned is that this systematic ECG and cardiac consultation can induce a delay for initiating the treatment, and in that case they observed a complication, ulceration in one patient. Another team, US team, they observed anomalies at the ECG in 25% of the patient, but none of them was a contraindication for starting the treatment. They had another approach. They established what is the cost, and it's a lot, only ECG here and not the cardiac consultation. But they also said that's a loss of time for the families to go to the consultation, and also it can delay the initiation of treatment. So we say, okay, the routine ECG doesn't make sense, but should be reserved to patients with bradycardia or any cardiac anomaly at the examination, or in case of personal or family history of cardiac disease, Face syndrome, and also when the mother has some connective tissue disease. There is another problem, because I have something on the screen which blocks the move of the slide. Okay. So are these adverse events, cardiac adverse events, frequent? It was in the consensus, US consensus, and when we consider the figures, globally, hypotension is 3 times more frequent than bradycardia, but asymptomatic events are 10 times more frequent than symptomatic. And globally, if you consider the symptomatic events, it's really low, less than 0.5%. So from that time, some publication about what is necessary for the monitoring after or when you initiate the treatment. So Jack made a ECG alter and did not see any anomaly or arrhythmia or AVB during the treatment in 44 patients. The German team, they established also the evolution of blood pressure after initiating the treatment. If there is a mean decrease of minus 5 millimeter, the blood pressure out of 95% percentile or lower 5% percentile was 2% and 2% of blood pressure anomalies during the treatment, but no bradycardia or symptomatic hypotension. And very recently, also another paper we established with alter ECG and blood pressure. So asymptomatic decrease in blood pressure of minus 6 millimeter, and also decrease in heart rate of 6 BPM at the alter ECG, but no change of the ECG, no arrhythmia. And these results in decrease of blood pressure and heart rate are very similar to those that have been observed in the international study, minus 7 BPM and minus 3 millimeters of blood pressure. It was not dose dependent between 1 and 3 milligrams per kilo per day. And when it occurs, it's mainly at the first hour here that you have this decrease in heart rate, but also blood pressure. Interestingly, when we consider approximately 1,200 monitoring sessions done during this study, there was only one case of bradycardia that occurred after the 2 first hours of monitoring and not detected during the 2 first hours. That means the risk to underdetect bradycardia if you limit the monitoring at 2 hours is very, very limited, less than 1 for 1,000. And what happened when you stop the treatment? After stopping the treatment, you have no rebound of heart rate. It's the same for blood pressure. And progressively, the numbers, the figures are normalized. So in conclusion, for the cardiac monitoring, you have this kind of conclusion in the paper in pediatrics. And the routine ECG or echo does not make sense and should be done only if there is any sign or history. And the same also for blood glucose, only in patients with diabetes or prone to hypoglycemia, and no systematic ECG during the treatment. What about population at risk? They are fragile population, premature babies, face syndrome, or some kind of very severe hemangioma. And the question for this population is how to do the titration to increase the dose, what is the therapeutic dose, and should we do specific monitoring in this patient? And for answering to this question, and at least to provide data, we expect to start a study in premature babies and also in face syndrome to document the condition of monitoring and to improve the safety. We hope to start this study. What about hemangioma at risk? There is a prospective study, clinical trial, a patient treated at 3 milligrams per kilo per day during 6 months at least. And this study of the recruitment has been finished and the treatment as well in Spain and Poland. And with this study, the result will be disclosed this summer. It will be possible to establish the duration of treatment and also the relapse needing to be retreated according to the duration of treatment. What about the dose? Just to consider that we used all the results of the clinical trial, international clinical trial, and that's a lot of data. And we use all this data of quality to make another analysis. It's not a statistical analysis, but it's like an analysis of big data. And that means you try just to find some factors that can modify the results. So globally, 60% of success at 3 milligrams per kilo per day, 6 months. And now, are there factors that can improve or maybe decrease also these results? Just consider the Milky Way. If you consider the Milky Way, you have thousands and billions, I would say billions of stars, brilliant stars. But you are not interested by brilliant stars. You are interested by groups of brilliant stars. And when you consider these groups of brilliant stars, that's in detail, you see all these brilliant stars, but what is interesting is this. And this you now analyze according to different factors. Is this group related to the distance, to the composition of a star, to the heat, and so on? So you do not know at the beginning what are the factors, and the system will just analyze that. So we did the same for infantile hemangioma, and to identify these factors of increasing the success rate or decreasing the success rate. And what we have seen, for example, we identified some factors. If you start the treatment early, it's something that you know. But here we could establish that, for example, less than 70 days of age, you increase the result, the success rate to 70%. If you have a large hemangioma, more than 2.5 centimeter, you are also a better result than if you have a small hemangioma, focal hemangioma. If you have a large hemangioma, but also a normal birth weight, you increase the result as well. And if you have an improvement at all the first visits, when you initiate the treatment, you have also an increase in the success rate. We also try to compare, it's not a statistical comparison, but to see the results. Are there conditions where 1 is better than 3? No condition, but 3 better than 1 and much better. For example, if you treat your babies before the 70 days of age, and you see the difference, 84% versus 56% of success. And the same for non-premature babies with a superficial hemangioma, it's 74 versus 47. So you have conditions where the doses are not equivalent and you can improve or not the success rate. There is also some results coming from the study done by the partner in Japan, Maruo, and they performed for the registration of the drug. In Japan, a specific study, they treated 32 infants, Japanese infants, at 3 milligrams per kilo per day during 6 months. That's quite high dose for them because, you know, usually they have a lower metabolism and they decrease the dose. So they use the same, and safety was good. Success was higher, 78%. But look, the PK data on the, fortunately you can see. Here on the right column, the triangle, blue triangle, that's the patient considered as a treatment failure. That doesn't mean that it was, the hemangioma was not improved, but just that it was not enough to have success in 6 months. But 6 of the 7 treatment failures here have the lowest blood concentration. So globally, they had a higher blood concentration than in the European population, French population, but in the same time, the treatment failure were with the lowest blood concentration. Lalia mentioned the results of sequela in untreated patients. And of course, now we have to document the type, the frequency, and the severity of sequela in patients treated with propanolol. And there is a study which is just starting in Spain and Italy. Usually, also, it's something related to the impacts of the hemangioma. It's not only quality of life or psychological impacts, it's something more global called burden. And a few years ago, we validated the HFB, hemangioma family burden. And with this hemangioma family burden, we have tested in almost 700 patients in 5 countries, including Spain. And the results have been published in Pediatric Dermatology in April. The same as questionnaire has been used also in the study of severe hemangioma that I've previously mentioned. How to improve the referral to the expert centers, and for that we have worked with a group of European experts, and the questionnaire, the score has been established now, and it will be tested first by experts and then by NAVE, primary healthcare professional, pediatrician or GPs during this year. And we expect to provide this very easy score to help non-experts to refer patients, the good patients, to the expert centers. And then, you know, sometimes there are studies that we have to do because it's requested by the authorities. Here we have 2 studies, one in France and the other one in Germany. It's ongoing, and it's just to control the condition of use of a product in real life. So we could say, okay, that's to control how it's used, and then you know, you are not right. But in the same time, it's also maybe to detect how we can improve the management of the patient and the safety, the security of the patients. So it's still ongoing at the time. The recruitment is almost finished, and we could also improve the condition of use in the future. So if you consider the figure I mentioned at the beginning, progressively we are answering to different questions. Of course, I have not mentioned all of them. For example, face syndrome, what is the dose, and so on. But the idea is that we are able to answer to this question progressively. So definitely, propanolol in infantile hemangioma is a therapeutic revolution. It's the treatment of first line. It's safe, it's efficient, and PFAB Dermatology is really committed to improve the knowledge about infantile hemangioma, to improve the treatment, the management of these patients, and to provide with you the best for these infants. Thank you.